Hello, everybody. I'm Dr. Anthony Cave, a Stanford and Harvard trained, board certified anesthesiologist and integrative medicine specialist. And I also run an integrative clinic with ketamine infusions to help patients overcome the most, the most debilitating mental and physical health conditions that they've been struggling with sometimes for years. Today, I'm going to share a really special story about a patient that started to have their surgery without getting the anesthesia. And how was that even possible? Because this is one of the more scary events that happened to me. I'm going to show you actually what happened with this IV. For those of you guys who are watching the video here, this is an IV catheter. It's a 22 gauge. And this is how we deliver anesthesia. But in this story that I'm going to share with you, this failed. And the patient started to go to sleep with the mask and wasn't actually getting any anesthesia. What happened and why was this perhaps one of the most dangerous things that could happen to a patient? But there was a happy ending. Nothing unsafe happened to the patient at the end, but something miraculous did pop up in the patient. So I'm going to share with you what happens when things go wrong in the operating room, even in the most dangerous times in surgery. First off, I want to say hi to Danny, Tom, Chris. Good to see you. And Michelle, Linda, Susan. I hope everyone's having a good Sunday morning. So let's get to this case and what we can all learn from it, because it's pretty incredible how this patient went through the beginning parts of the anesthesia process without actually getting anesthesia. Now, you have to know, first of all, that anesthesia is not just going to sleep. It's not just a mask that goes on your face like the one that I'm holding here, and you're just sleeping through a surgery. Not at all, because when you're under general anesthesia, you're actually in a medical coma. This is important because when you're in a medical coma, your brain and all the nerves in your body are turned off. And when your nerves are turned off, it means that they're not functioning normally. So where are there nerves in your body? In your heart, in your brain, obviously, in your digestive tract, in your bladder, your muscles, pretty much everywhere in your body. Which, by the way, for those of you who have heard my other shows on this, we talk about clinical hypnosis and how when you can control nerves in your body, you have the potential to control wide-reaching effects in your body, because those nerves are everywhere in your body after all. So anesthesia is like a short circuit way to entering a hypnotic state. Now, this patient had the mask on, was getting ready to go to sleep, and I was giving them propofol through their IV. It was actually a 20 gauge. This pink one is 20, so I'm holding it up here. It's actually a little bit thicker than this 22 gauge. You can see the difference in the diameter there. Yeah. Well, I gave them, actually before the propofol, I gave them a little bit of sedation to do a nerve block first. And just so you guys know what a nerve block is, I use a needle like this one here. These are all expired medical supplies, by the way. This guy is pretty thick, it's pretty fat, and I give some sedation before I do the nerve block. This patient was having an ACL surgery. So I was doing nerve blocks around the knee. I was placing this around, in this case, the adductor, around the saphenous nerve, and the genicular nerve. So those are the nerves that I block for an ACL. It's not painful, but it can be uncomfortable, which is why I give some sedation. Well, I gave some sedation through that patient's IV. This patient was so chill coming into the operating room. We were just chit-chatting as I was looking with the ultrasound to do the nerve block. I gave, before the propofol actually, just some midazolam and fentanyl. Now, this patient was so relaxed. I say, hey, do you feel that first bit of anesthesia kicking in? He's like, yeah, I feel great, doc. So I proceed with the block. I proceed placing this, relatively, it's not painful, but it's not a small needle either, right? I numb the skin first with a very small needle, so when the bigger needle goes in, it doesn't hurt as much. But the point here is that we do the nerve block, he's doing great. As we get ready to go to sleep with the propofol, I push it in, and we're just chit-chatting, and I'm waiting for him to fall asleep. It's kind of like, when they say, oh, how long can you count down for? Well, usually, maybe you go from 100 down to like 94, 93. If I ask them, if they're really giving me a hard time, sometimes I'll ask patients to count by sevens. So, 100, 93, let me think a little bit more. This was just counting by ones. The patient was getting to like 80, 74, 73. And I'm like, this is weird. So this is the danger that I had to talk about, that I mentioned at the beginning. It's called an infiltrated IV. For those of you guys who know this, it's when this little 20 gauge catheter or 22 gauge, whatever you have, slips out of the vein and goes into the soft tissues around the vein. This is incredibly dangerous when it happens in surgery, especially if it's your only IV, because your IV is your lifeline. The point here is that this patient was so relaxed, and for reasons we'll get to, he said that he felt the relaxing effects of the anesthesia, even though when I had given him the first bit of relaxing medication, the midazolam and fentanyl, he never actually got it. So how is it that somebody could feel so relaxed and feel the effects of anesthesia going in, at least the sedation one, and then only me realize when the propofol is supposed to put him under general anesthesia that it doesn't work? First of all, why is it so dangerous? Because when you're going under general anesthesia, your brain and body go into haywire mode because your nerves are suddenly, very rapidly being turned off in your brain, brainstem, and parts of your spinal cord. Because it's so rapid, there's the risk of dangerous things happen. One of the most dangerous is laryngospasm. In addition, sudden low blood pressure, sudden bradycardia or low heart rate. These are things that we need an IV, the ones that I'm showing you here, to rapidly give emergency medications to fix the problem. Because it's a sudden onset of anesthesia, there's a risk of sudden emergencies happening. It's one of the most dangerous parts of any surgery. But the IV isn't working, so some anesthesia went in, and some of it gets absorbed eventually, but and at this point, I wasn't aware of how much had gone in because he was starting to look a little bit sleepy, but was not going fully under anesthesia. So very dangerous, because I need to place a breathing tube like the one I have here. I'll show you, for those of you guys that are watching, this breathing tube's got to go in to your mouth because you stop breathing when you go under anesthesia. This is the little stylet that we use to help guide it in place. But if you're not getting a full dose of anesthesia, I can't place this breathing tube to keep you alive, right? So it was like a little mini emergency there. I quickly had to get another IV in him within seconds, because otherwise there's a risk of these, like I said, laryngospasm, hypotension, bradycardia, ultimately cardiac arrest can all happen within a minute or two if one of these emergencies happen and I don't have an IV in place. So fortunately, all went well. And I got the IV in place. We went fully to sleep. But how come this patient how come the patient felt so relaxed when I gave them the midazolam and fentanyl, but it never actually reached their brain? I'm going to leave you with that for 1 second here, because a bunch of questions have come in. How do those rubber needles puncture the skin, asks Danny, because I'm not showing you the needle that goes over them, because I don't want to poke myself accidentally, but I can demonstrate. Let's see if this works here. This little bit of flexible nylon first goes, it's over a sharp needle, and then we pull the needle out, and this is what's left inside. You see, it's just like nylon plastic. It's not hurting you, but it first goes in with a thick needle like this. Lucy, what do you do if someone had a panic attack before having anesthesia? Lucy, if I have an IV in place and they're having a panic attack, maybe from the claustrophobia of the mask going on, I give IV propofol or midazolam, depending on the situation. Of course, I always prefer non-pharmacologic, non-medical ways, non-medicine ways of doing it. But if I don't have a choice, I'm going to have to give whatever I have to make sure everything is safe. How did I figure out the vein was missed? Mrs. Eyes, you ask a good question. Because when you have an infiltrated IV, meaning this catheter is slipped out of the IV, you see fluid rapidly expanding. Usually it's painful. This particular patient was in such a trance, was so relaxed, they didn't even feel the pain. It's as if the medication I gave them in the beginning had actually worked. I learned later that it had not gone in, but in the moment when someone is so relaxed because they have self-entrained themselves into this type of relaxed, almost hypnotic state, their pain perception is reduced, because remember, pain is 100% in the brain. We'll talk about that in a different different stream, but you or in this case, the patient had incredible control and didn't even feel that their IV wasn't in the right place, but yet felt the medications from the suggestions that I was giving, the clinical suggestibility or the clinical hypnosis that was getting them into that state. Great question. Photocan, good to see you. I've been researching about anorexia nervosa. Would love to know how you would deal with a patient who is severely anorexic, BMI of 11, and needs surgery. Well, Photocan, you don't do surgery in someone with a BMI of 11 because of the risk of electrolyte abnormalities, post-op surgical recovery. You cannot heal your wounds if you don't have the proper nutrients in place. If you're severely malnourished, you have bradycardia, the risk of arrhythmias, either from electrolytes or from other reasons that we never do elective surgeries in cases like that. If it's an emergency, then we give whatever medications we have on hand to help artificially boost the heart and lungs. And sometimes give artificial nutrition after surgery. Good question. Michelle, good to see you on. What would you have done if you couldn't get another IV in? Should we ask to have multiple IVs just to be safe? Great question. It's very rare for this to happen. This patient was just so incredibly relaxed that it's very rare. I've had this happen maybe like twice in the last 10 years that I can think of, where somebody is in such a trance as they're falling asleep that it's almost like they're getting IV anesthesia, but it's really a powerful hypnotic and placebo effect. Placebo is very, very powerful. And this is one of the cases where we see it in the operating room. I'm not saying placebo is dangerous, but I'm saying that this is a relatively extreme example of it. Having a second IV to start is not common practice unless there's other extenuating circumstances requiring it. Healthy healings. Yes, Chris, I see you. How are you? And Darian, good to see you as well, my brother. Can I speak to CRNAs and relationships with them? I do not supervise CRNAs, Chris, so I can't speak to that. I only do what's called solo cases. I take care of my patients. I call them the night before. So I'm the one directly caring from they know me from before throughout the surgery. I prefer to be with my patients one-on-one for many personal reasons. And okay, so I got to get back to this concept. This patient was in such a trance, and what led him to reach that state? One, it helps when, as I said before, I call my patients the night before. So they form a relationship with somebody. Trust and a setting of compassion and care, but most importantly, trust is key, absolutely key, if you want to have a healing experience, as opposed to a traumatic experience. Because like we said before, PTSD after surgery is probably more common than we're aware of because it's very difficult to diagnose PTSD from surgery because all the anesthesia we're giving messes with your memories and people can't remember the trauma that may have caused their sensations of hyperstimulation, hyperarousal, sympathetic surge. When you have trust in that care team, you not only reduce the risk of bad things, but you also increase what we call the resilience factors, as opposed to risk factors of good things happening, like being so relaxed that you don't need as much medication. You have less of a chance of waking up delirious, which has its own set of potential risks after, but less chance of having acute pain, transitioning to chronic pain, etc. This patient was really exemplified that mind-body relationship to put himself with seemingly no anesthesia at all because I know it didn't go in the vein in the first place. It's very rare when you almost have like a laboratory where this happens. Fortunately, nothing bad happened, but it was an observation that's valuable. This individual clearly has the high hypnotizability characteristic, if you will, and it can be used for healing because clearly the pain of that nerve block from the needle that I just showed you didn't faze them at all, whereas many other patients would probably not have tolerated it the same way, would have maybe had anxiety, panic coming up, but this patient completely. And I was monitoring them on the monitor, so I know their heart rate, their blood pressure. It wasn't in a way that you would expect from somebody who was in a, I would say, placebo arm, but clearly this patient was in an effective placebo. So let's answer some questions here about any other stories or any other thoughts about clinical hypnosis and placebos before surgery. Kay says, I had a panic attack before the surgery I had Friday. The poor anesthesiologist remembered me from another procedure that I had a panic attack before as well. He was ready to help me. Good. Kay, I hope that you're doing well after your surgery. I hope you're recovering well. And Dave, good to see you on. Why do they leave the breathing tube in after open heart surgery? Dave, when you are having open heart surgery, you get a breathing tube in. You're correct. After open heart surgery, for many different reasons, we sometimes choose to keep patients asleep for a couple of hours or a day after, depending on how the surgery went and depending on how that institution does open heart surgeries. If you're kept asleep after open heart surgery, you're not breathing on your own. That's why we have to keep the breathing tube in place. But if we wake patients up, we remove the breathing tube. Good question. So Mrs. Eyes is saying the power of suggestion is very powerful in some people. What is some people, Mrs. Eyes? About 50% of the population is very hypnotizable, meaning that they are very open to suggestions that allow their minds to control parts of their body that they probably did not think they could control before. And I'm talking about things like nerves in your lungs that might contribute to asthma, nerves in your gut that might contribute to IBS, constipation, or diarrhea types, nerves throughout all of your spinal cord that transmit pain signals to your brain, fibromyalgia, etc., phantom limb pain, nerves in your brain itself that might contribute to depression, anxiety, etc. Suggestibility is simply allowing an exogenous force, like a medication could, to impact the nerves in your body from your brain moving downwards. 50% are highly are hypnotizable, 25% highly, 25% less than average. So it's like a Gaussian distribution where most patients can be hypnotized. Chris is asking, wonder what his feelings would have been had he not been relaxed prior. Well, Chris, I'm telling you, when patients get nerve blocks, depending on how much they've been prepped for it, because the more preparation you have, the more certainty you have because you know what to expect for anything in life, right? But when patients don't know what to expect and they're just having needles jammed in them, the reactions can be very severe and it can be problematic because maybe they're going to move their leg, their arm, hit me, hit the nurse, disrupt the surgery. So it's not a matter of just convenience and for patients to be relaxed. It's a matter of safety. Okay, Rahul Thomas, I'm gonna have to ask you to stop spamming the chat. Yeah, hopefully that's not intentional. Okay, great. These are great questions. I can't bear to stop now. We'll give it a couple more minutes because I want to answer your very good questions. Hey, PhotoCan, in your opinion, is it possible for PTSD to be linked with physical pain, like pervasive tension headaches, not only after anesthesia? PhotoCan, yeah, it's not a matter of opinion. Any experience that occurs in an area where you don't have support, where you don't feel like you can trust what's going on, you don't have faith in the system, etc., is a potential for that memory to be encoded abnormally in your brain, which can then in the future be recalled as a traumatic experience and have PTSD symptoms. Whether that's physical pain, emotional pain, doesn't matter. Now, headaches causing PTSD, it's not the classic type that we think of in terms of like when you think of military individuals, people in an operating room, adverse childhood experiences, etc. But certainly there is no end to possibilities for what might cause PTSD if the trust and the support around that individual are not there when that type of pain or traumatic experience is occurring. Faye, good to see you. How does anesthesia differ from someone having a very invasive surgery like brain surgery to something less invasive like gallbladder? 50% of the anesthesia is about the same, but there are many small differences between, for example, gallbladder and brain surgery that involve how we monitor the heart, the brain, the medications that we use to allow the surgery to safely happen on that specific organ. So there's about 50% same, 50% differences. Michelle, I'm happy that you also agree with Kay on that. Just like we were talking about, if you're having a panic attack, your doctor will treat that. in the moment with medications if needed. Because once you have an IV, remember, when you have the IV in place, we can do emergency abortions. I shouldn't say abort panic attacks very quickly with medication. But what we talk about on this channel is ways that we can also do it outside the operating room, modified Valsalva maneuvers, kicking into curiosity before the panic attack happens, et cetera, et cetera. It's about resilience factors just as much as risk factors. Good. Lucy Thompson has been putting off surgery for so long, and the anesthesia is the part that she's most scared about. You're not alone. And Lucy, I hope that you look at some of the other videos that I put up recently about what to tell your anesthesiologist if you're afraid before surgery, and ways that you can empower yourself with like what you're doing right now, exposure therapy, and learning what to expect. Because the more prepared you are, the more you can have certainty and confidence. And if you remember, the ways to overcome anxiety are certainty, curiosity, confidence, the C's that I've talked about before, control. You can't have control and certainty if you don't know what to expect. So you're doing, Lucy, I'm wishing you the best, and I hope everyone here is wishing you the best as well. So, hey, just as a shout out here, I would support, of course, if you guys share what you learn with other people so that you can help empower others to know that they have more power over their health than they've probably ever been told. Just like this individual that I'm sharing in this very rare occurrence, demonstrating how powerful their mind was to control the situation, even though it was an emergency. Not any ordinary patient would have been able to undergo that as smoothly and as relaxed. Having an infiltrated IV, getting a nerve block without sedation, having the anesthesiologist quickly run and put another IV in, being jabbed and poked again and again and again. Many patients would not have fared with such a relaxed way and such a safe way in this scenario. And I attribute it to that patient's state of mind and mind-body control to be susceptible in part to the hypnotizable affirmations I was giving, but also their sense of control, confidence, and to an extent curiosity about what it was like to be in this experience, because we had primed him for it the night before. Of course. Chris, speaking of IBS, why did it take so long for IBS to be diagnosed as a medical issue when we know stress plays a huge role in it? Chris, I don't know the answer for why, other than what we know as a medical community, that when we have difficulty finding an organic explanation for something, we don't like to attribute it just to stress. For good reason sometimes, because, hey, if someone comes to the emergency room and they can't move their arm, could it be conversion disorder? It could be, but we need to make sure that it's not something specifically organic that might be immediately fixable, like a stroke or an infection that might be preventing them from moving their arm. I can't just go around and say, oh, were you stressed recently? No. You go to the CAT scan, we make sure there's no brain bleed, we do an NIH stroke scale, et cetera, to make sure that we take care of the emergencies first that might cause lifelong debilitations and complications. Medicine in the West is focused on short-term acute. What's going on in the moment? What can we measure to quickly make a change? And it's life-saving in many, many situations. But it comes at the expense of long-term perspective about, what led to the heart attack? What led to the stroke in the first place? After we deal with the acute stroke, can we address what led to the stroke in the first place? In the case of IBS, well, we've ruled out a bad infection in the gut. We've ruled out celiac. We've ruled out the nasty things that can cause malnutrition, that can cause other major complications. But you're not dying, go figure it out at home. That's unfortunately the mentality that a lot of Western medicine has. It's life-saving, but has consequences when used in a silo instead of a holistic way. Okay, healthy. Okay. All right, Chris, I'm gonna end with your question. What would the emotional outcome have been in this patient if they were not so relaxed before surgery? Well, Chris, first and foremost, I'm not going to pretend to have a crystal ball. We've got to practice humility here. I don't know what would have happened, but I suspect if it were like other patients that go to sleep or have an intervention done when they're very anxious and more likely to kick, scream, wake up delirious, have more pain than a counterpart having a similar type of procedure or surgery, have a greater chance of acute to chronic pain transition after, greater risk of post-op delirium. Well, I would expect any one of those to possibly come out from an emotional mind-body perspective instead of just chilling through the whole thing as if nothing out of the ordinary was happening. I am just so impressed and inspired by patients that buck the trend the way that this patient did. Darian, do I have cool socks on now? I don't have cool socks, unfortunately. Otherwise, I would show them to you. Okay, a couple quick. All right, Michelle, I'll end with you. Do you need a paralytic for a nap for an appendectomy? Yes, paralytics go in for laparoscopic appendectomies because of the pressures that go into the abdomen that prevent. Wait. Who knows where that ringtone is from? I'll give anyone a giant shout out if they tell me where that ringtone is from. But just all right, the second someone tells me where that ringtone is from, I will give you massive shout out, and that'll be the end of our session today. But Michelle, if you have high insufflation pressures in the abdomen because you're ballooning it up to allow the cameras to go in to remove the appendix with minimal surgical intervention, like small holes instead of a giant scar, you can't be breathing on your own because the pressure in the abdomen is simply too high for the asleep patient to breathe against. So we need to mechanically ventilate you with the breathing tube. You cannot mechanically ventilate somebody adequately and safely without first paralyzing all their muscles so the ventilator can do all of the breathing. Darian, the dog and cat are doing well. The cat sleeping in the corner. And nobody knows where the ringtone came from. Well, I'll have to give you a shout out in the next live. So if you know where that ringtone came from, please leave a comment, and I will certainly start with a shout out next time. Although I do see Faye said, I had 4 brain aneurysms, 2 of which I had to have major brain surgery for. All right, last chance for the ringtone, by the way. I can't help to feel like it's a ticking time bomb. All right. Faye, I'm so sorry that you have 4. If it calls again, I'm going to pick it up. All right. Sorry, guys. I don't know. Sorry, guys. I'm going to have to pick up this call. We'll answer the rest of your questions next time. No one's got the ringtone yet. It's not Star Wars. It's not Mario. You guys have more power over your health than you've ever been told. Someone's clearly trying to get a hold of me, unfortunately, in this profession. I sometimes got to pick up the phone. Hope everyone has a good weekend. We'll get to the rest of your questions next time. Raul, I do see your questions, and I don't know how to answer your question about will anesthesia specialty change. Everything changes in medical education, including our specialties. So I can answer your question, Raul, in the future if I better understand it. Hey, until next time, y'all have more power over your health than you've ever been told.